Again, another patient who had an effort angina. Okay. He has a huge dominant right coronary artery, and you could see that it's a calcified critical stenosis in the right coronary artery.
Right.
And you can also see that there is a retrograde filling of the left system, left coronary from the right coronary.
Yeah.
And show the next image. So that's the one we are planning to do today. And you can see the retrograde filling of the left antidescending artery. Next one.
Yes.
Show the pressures once again, and show the LAD also. Okay. The circumflex looks reasonably good. The LAD is occluded.
Yes.
It was a
Short
CT of
segment
the.
CT.
It was a short segment CT of the LAD, which was calcified. Next
Caput.
image. Show the next image also. That's the calcified pressures.
Yes.
That's the calcified occluded LAD. So that was done couple of weeks ago.
Okay.
Today we are planning to have the right coronary done.
Okay. Is it a CTO or acute and chronic CTO or ATO?
It was a difficult one. We had to do multiple parallel wiring and all to get
right.
across. Show the CTO also.
Which one crossed Gaia?
It was Gaia 3.
Okay.
Gaia 2 went subintimal, and Gaia 3 ultimately
Parallel wire it crossed.
parallel wire with Gaia 3.
Okay, program.
Show that images also. Pericardium okay. Pressures are okay. Yes. Enough. So we tried crossing with Gaia 2.
Yeah.
Next one. Next one. It was always subintimal. It took quite a long time. It was going subintimal in all the planes, whatever we tried. Then finally Gaia 3. Next one. IVC.
Yes, it went. Yes.
Now this is again. Now finally it went in.
Yes.
Show the next. Keep running the images. No. Now again it was subintimal.
Oh, no.
Subintimal. Now finally the Gaia 3 crossed.
Extra plug, intra plug, it went.
Class 640.
Good.
Class 640.
So that is a fibrocalcific lesion.
It was a fibrocalcific lesion.
So that's why you find some difficulties. Right.
Because it was a CTO, it was done with IVIS guidance.
Guidance.
So today we are planning to have the RCA done.
So true. Good result. Very good. I think here the protruding calcium will be there in RCA because of its very hazy lesion at the site of maximum tightness.
Next
RCA.
Is that the last one?
Good result.
Next.
Yeah.
That's the last.
Yeah, very good result. So, for this actually,
I
again,
think
OCT
probably
guidance you want to do OAD, orbital atherectomy, RCA.
Pardon me?
Your strategy is OCT guided orbital atherectomy here.
For the right coronary today. For the right coronary.
Yeah.
This right coronary appears to be a much bigger vessel.
Yes,
Ari, can you again show that RCA that we are going to do today?
Very classical concentric tight lesion with a protruding calcific block causing haziness at the tightest lesion. Yeah, you can see the concentric calcium.
This probably will be seeing more of some nodules and all.
Yes, exactly.
We'll go with a New York OCT catheter.
Yeah. You'll see whether my catheter crossable or uncrossable.
Yes.
One uncrossable means you have to do atherectomy directly. Orbital atherectomy. So here you will take JR. Again AR.
We prefer the previous one. Probably we would have we should have chosen a JR. It would be
No.
more easier during the
Exactly.
managing the guide catheter would be
Maneuvers.
easier, but then getting the stent, tracking the stent,
Yes,
tracking
correct.
the OCT catheter would have been difficult.
True, true.
But then this pressure damage. Now you didn't see the hemodynamics during the procedure.
Yes,
There was significant pressure damaging every time we had to disengage the guide catheter.
Not
That's
just
the
the
reason.
position of catheters. Only
Yeah,
you have
that
to
was the
spend
reason
time.
why twice you saw the guide catheter. Why is
Yes.
everything coming out?
True,
So
true,
here
true.
this looks more of a roomy right coronary ostium, so we'll be more happy with the
Yes,
short
correct.
amplats
Exactly,
catheter.
you are correct. Another thing what I observed is usually 7 French JR almost it gives a very supportive catheter like AR and AL.
Very true.
7 French if you take.
Yeah,
Then
very
you can guide extension catheters are easy and all these 6 French free movement and exchange with the means of balloon occlusion
Very
methods for
easy.
removing the micro
In a
catheters.
setup.
All these methods will be easy.
Orbital? ಇಲ್ಲ പിന്നെ പറ yes, pressures are good. Yes. We'll go sit and discuss. By the time we'll get the next one ready.
Suppose if your primary option is only IVL without ablation, within 4 months patient becomes with angina with again protruding nodule into the stent. I have seen almost 5 cases. Very difficult to convince for the surgery. That's a disadvantage. If your primary option is IVL for nodule, yes, you get very good acute result. But after 4 to 6 months, patient become angina with again the nodule inside the stent it will come. I have seen, that's why I'm telling. No, suppose if I do nodules 10 cases, 10 cases, I have seen 2-3 cases. I have to send for surgery. That's why I become, whenever my strategy is only IVL with the nodule means, I do not advise. I always do atherectomy. That's why Dr. Kashim also told, reduce the volume. Nice. Yes, came back. That's why I'm telling. Only both means did not come. Once you reduce the volume, followed by, that's all. Without reduction of the volume for the nodule, high rate of recurrence. Just to only modify the plaque and compress it, they will come in like a ball, it will come back. Reduce the volume, then do the, then safe, no recurrences. No, because yes, true, recurrence is high. Recurrence, true. I have seen the focal lesions. I did IVL actually because atherectomy I did not see. With atherectomy. Yes, true. Once you reduce the volume, the recurrence rate is very less in calcific lesions. Because in the focal calcific lesions, we are tempted with only IVL, isolated IVL. So for that, I got very good results actually. But after 4 to 6 months, patient coming with angina and all these things, I become mad actually. After spending 3 lakhs, patient coming back means we can't convince. Of course, known patients, attached patient, long standing, they will undergo surgery with new problems. I have seen these cases. Very plenty of real world difficulties with IVLs, with rote and everything. We got all these bulk experience with these devices. Calcium itself, that's why I'm telling. Calcium means you have to do more and more kasrat. You have to do. You have to sweat more. CT1 calcium means. CTO side. Basically, the principle itself is where it goes into extra plaque, where it goes intra plaque, difficult in case of this one. You see, in this case, same. And the orbital atherectomy, once it goes extra plaque itself, is a contraindicated, because the basic principle of orbital atherectomy is it will cause the axial movement and cause the wall weakening, wall plaque reduction. So once it brings extra plaque, the chances of perforation is very high. That's why CTO, unless you confirm the lumen, intraplaque, again human, then you can do orbital. But in the IVUS, once it goes extra plaque, again the plaque and the extra plaque, like that, you should not do orbital. Because where it going extra plaque, chance of perforation is high. The basics. Yes, correct. That is the advantage. Here the laser has a more role. Yes, laser has more role than the orbital, and for focal, by means of you can tip in, you can do wedge it, and then you can exchange with the rota wire or viper wire. But once it is a long segment CTO, laser has more in weakening this one. For balloon uncrossable to crossable. The same wire, you need not exchange the wire. That is the advantage with the laser. Again, you have to go very slowly, millimeter by millimeter, like orbital. That's why sick patients will be like this. Oh yeah, and lasers. Limited, you are correct. Because heavy calcific lesions, lasers are out. Only moderate, mild to moderate only it will work. For soft lesions, it will operate, it is very useful. Work thrombi. Yes. True. Yes. Real indication. You are correct. Absolutely. Yes. True. Especially fibrotic lesions is very useful. Fibrotic lesions, it is very useful. In ISR, fibrotic lesions, laser is very, very useful. Calcific lesions, IVL is very useful. ISR. Good olden days, these rota, but rota is unsafe. What I have seen, you can do heroically, but suppose it will given away, suddenly it will go like that, because it is highly resistant. As the resistance is more and more, the long jump will be more and more with rota. That is the main drawback. Yes, calcified. Yes, correct. That is the main. No control. Once given away means sudden. Yes, correct. Yes, correct. That's why sudden gives away, it is not under our control. I think the TPA might be put that. Okay, sure.
അത് ഡിസ്കണക്ട് ചെയ്തതാ. It's all right. ഇത് റൊട്ടേറ്റ് ചെയ്യാൻ പറ്റത്തില്ല, നിങ്ങൾ അങ്ങനെ കണക്ട് ചെയ്ത് തന്നു കഴിഞ്ഞാൽ. അതിനപ്പം വേറെ ലീഡ് ഇതാ. ബലൂൺ ടൈപ്പ് കുഴപ്പമില്ല. പക്ഷേ ഇത് ബലൂൺ ഓൺ ചെയ്യുക, ബലൂൺ ഇൻഫ്ലേറ്റ് ചെയ്യാം. ഓക്കെ, ബലൂൺ ഡിഫ്ലേറ്റ്. ഓക്കെ, കണക്ട് ചെയ്തേക്കാം. ഒട്ടിക്കാം. ഔട്ട്പുട്ട് at 5, heart rate of 100, rate of pacing of 100. അത് ഓഫ് ചെയ്ത് വെച്ചേക്ക്. കണക്ട് ചെയ്ത് കഴിഞ്ഞിട്ട് ഓൺ ചെയ്യും. ഹൺഡ്രഡ്. ഇല്ല, ഇറ്റ്സ് നോട്ട് പേസിങ്. ഇറ്റ്സ് നോട്ട് പേസിങ്. ഇല്ല, അത് ഫസ്റ്റ് സ്വിച്ച് ഇറ്റ് ഓഫ്. Switch it off. Now connect it properly and then switch it on. This switch it off. ശരി, ബലൂൺ ഇൻഫ്ലേറ്റ് ചെയ്യാൻ ഒരിക്കൽ കൂടെ. ഇയാൾ തല അല്പം താഴ്ത്തി തരുമോ? ഓക്കെ ഓക്കെ. ഓക്കെ, give the guide kettite.
Guide. Six French.
Yeah.
Sheet is 6 inches. See, slender.
Yeah, we have a slender sheath in
slender
the
sheet. That's advantage, actually.
slender sheath in the radial.
Yeah.
And then going with the 7 guide.
Very useful.
Okay. OCT, is it ready?
Very.
Get me another Y catheter.
Sister, inko Y connected.
Get me another Y catheter. Keep the OCT catheter ready.
Y connected.
1/4 wire.
I'll give injection.
Yeah,
So I'll give injection.
Yeah.
Yeah.
Okay.
Very good, sir.
Come to elevocranial. We'll have the fluid running fast. It's not flowing. Get the fluid running fast. Keep a small dose of noradrenaline ready. The BP is 100, 110. We would want to keep it at around 140 or so. A small dose of noradrenaline also. Okay. Shall we take an image?
In the concave side, more thicker calcium is there.
On the
Concentric calcium.
Yeah.
Inner curvature.
Vishnu, can you hear us?
Yes, sir.
Wide.
Hear you clearly.
Can you hear both of us speaking, Dr. Kapardi's
Yes, sir.
mic also?
Yes, yes.
Wide we can.
Wire? We'll initially take an OCT run. After the OCT pullback, we'll go with the orbital.
Darkening. Put the darker.
Pradeep, can you show the hemodynamic monitor also on the screen? Is it possible?
Yeah. Yes, that's all. Yeah.
Okay, get the OCT catheter.
Yeah.
20 cc syringe. Can you do a small purge of the OCT catheter? No, I was asking if you can show the.
I'm holding the.
What about images? Show the images. OCT image. Show the OCT image.
Yeah. Yes.
Okay. Auto calibrate. Okay. Now we'll go in. Shall we come closer?
Yes, crossed.
Okay.
No.
Okay. Are you ready with the? I'll ask you to activate and then. Okay. The guide. No. Hold on. The guide is out.
Yes.
Okay. The guide is okay. Okay. Yes.
Yeah.
Yes. Activate.
Yes.
It's always good to wait till the lens it goes back to the original position and then take out the catheter.
Yes.
It's gone back to the resting position and now pull it out. Get me another 7.5. Meanwhile, be ready with the orbital device also.
Microcatheter.
Well, can you see the OCT images?
Yes, sir.
Vishnu?
Yes, yes.
Okay. So, in this view, these areas appears to be a decent landing zone wherein you are able to see 3 layers of vessel almost 180 degree. So this appears to be a reasonable landing zone. Now from there we come back and assess the lesion. Here it is more of fibrotic with some specks of calcification. Now again that's a nodular protrusion into the lumen. That's what you see. It's very close to the imaging catheter. Then as we come more proximally, again that's an eccentric calcium. Now we see almost the 180-degree arc of calcification from 6 o'clock till 12 o'clock position. You do not see much of concentric calcification. And then as we come more proximally, again an eccentric calcification in 9 o'clock position. Here there appears to be some nodular protrusion into the lumen. And then here again, this is more of almost 180-degree arc of calcification. That's actually a nodular protrusion at 1 o'clock, 2 o'clock position. It is little bit away from the imaging catheter, but still we hope that probably the orbital should do something for that. And then as we come further more proximally, these areas you have thick calcification, more than almost 270-degree arc. Here it's almost 270-degree arc. It's a thick calcium. And as we come more proximally, here again you are seeing at 11 o'clock position there is a nodular protrusion which is very close to the imaging catheter. And then as we come more proximally, at the tightest area, that this area is the tightest area, you are seeing a nodule. It is all, you do not see any eruptive nodule, it's more of nodular protrusion that is actually close to the imaging catheter. We hope that in this particular case, certainly the orbital should shave off some amount of calcification. And as we come more proximally, here again there is calcium. The good thing is we didn't see any 360-degree arc of calcification. We saw nodules, we saw certain areas wherein it's very thick. This area it appears to be very thick, but then we wouldn't mostly do anything to this calcium with the help of orbital or even any balloons. Wouldn't really do much for this calcium. The stent would expand on the other side, so probably we shouldn't be very aggressive at that particular area. So that is what we see. And then regarding the length of lesion, probably should be from here. If you look at the yellow box, the area seems to be reasonably good over here. So we'll have the distal landing zone somewhere here, and proximally, if you look at the yellow box, it should somewhere come over here. So this would be the proximal landing zone. It's almost 57 millimeter. Probably we'll go with 2 stents. And then probably the vessel size distally and proximally. Here the vessel would be almost 3.5. Distally it's almost 3.5, and as we come more proximally, the vessel size here should be more than 4.
4.5.
It's almost 4.5.
Yes.
So that is what we have seen. So probably a 3-point stent would be 3.5 stent, not very aggressive deployment would be ideal, with 3.5 post dilatation in the proximal distal portion and 4 mm post dilatation in the proximal portion. We'll do modification with orbital followed by a we prefer using non-compliant unless it because again the cost issues are always there. So the balloon based strategy would be, first option would always be non-compliant balloon. So we go with orbital now.
Sir, in this, what speed you will use? 80K, both 80 or 120?
Balloon occlusion.
Yes, Vishnu, you can answer that.
Because lesion is, because the vessel size is bigger.
It's much big, true.
Much big, so
yeah.
Go first initially 80, then followed by.
Yes, that's a routine practice.
120 also you can do.
And that's a routine practice. A vessel which is more than 3 millimeter in size, we can go at higher speeds, but then always try to modify the lesion with 80,000 RPM, and then finally 1 or 2 runs with 120,000 RPM should certainly do good in this particular vessel, because it's more than 3.5 in size. The other one was 2.75, 3-ish vessel. That was the reason why we didn't go at a higher RPMs. So here we would start with 80,000 RPM and then go ahead with 120,000 RPM also. Now again, regarding the orbital, can you focus on to the table? Can you focus on to the table? So here, this is actually the device. We have, what about this? What about the saline? Is it ready? Shaidi knows Kapardi sir very well.
Yes,
she worked with you for a few years.
Apollo,
Yeah. She was excited when we told that you were coming over here. Okay, so the two connections, one going on to the motor, that is the electric motor, the power comes from the pump, and the second one it's basically for the purging that we have 500 cc ideally we should have taken a 1000 cc 1000 ml bottle, but we have two 500 cc bottles with 10 ml of wiper slide inside each of this. Now we are trying to flush it, prepare it ready, get the thing ready, and by the time we'll have the wiper wire going in. So would you go with the we'll go with the wiper wire. We just push it. You want to trap it, and
we can go with this. No, here it is.
You want to trap that microcatheter. We just try. We just try pushing it. If it goes in if it goes too deep, then probably we'll trap it, and this is what we try to do in most of the. Okay. It's a New York microcatheter, so it goes in without. Okay, get the wiper wire also.
No, I can.
If it's an Oxford microcatheter, it's always a difficulty. Always a difficulty.
N microcatheter here. Okay. Usual term. Master strike is 1 meter. Wiper wire. Wiper.
ഇതൊന്ന് പിടിച്ചു തരോ, ഇതൊന്ന് പിടിച്ചേ അനീഷ. So regarding, can you again focus on to the table? Sheen undo, Sheen. Okay. Can you focus on to the table? Again the device. Again the device over here. We have the flush coming in, and then we have the handle. We have the advancer knob. We keep it always locked. We keep always the advancer knob locked. Open means it's ready to fly, so always keep it locked. Then we have again two switches to toggle between. The one is for low RPMs, and the other one for 120,000 RPM. Then we have the glide assist mode also. To go in and take out, you can go at 5,000 RPM. It's just 5,000 RPM. You just have to hold on to that for a while so that it becomes 5,000 RPM. Then that's it. Then again switch on, switch off button, and again the lock, again the brake. Okay, these are the things that we need to keep in mind. Okay, now we have taken out the microcatheter. We have taken out the microcatheter. We have the wiper wire inside the vessel. Now before we go inside, we'll get the orbital atherectomy crown near the Y connector, and then try checking all the parameters before we go in. And that's the crown. Can you focus on to the table? Most of the time, like the rotawire, this also will unravel by itself. While using this wiper wire, you feel more confident compared to the rotawire. Rotawire, you have to be very careful. You have to be very careful not to bend it. But then this one, it's much more easier to handle. Also be ready with the atropine. Okay, now we'll check all the parameters. First thing, the flush. Okay, can you focus on to the
this one, please.
This particular area. Okay, it's focused. Yes. Now we are seeing the saline flush flowing well. Now we'll check if the burr is working well. Yeah.
Can I start?
Yes. The brake.
No, sorry. You have to.
Okay.
This is important.
Okay, we'll switch it on. The switch on button.
No. 1 minute. Lock.
I think the brake is not fully down. Okay. Now it's down.
Now it is click.
Okay. Now that's good. We'll switch it off. So we have seen that it's
front and back.
Now the third thing is, look at the advancer knob. Show this particular area. Okay. Make sure that the knob is moving forward and backward, smooth.
Yes.
And then finally, regarding the brake has to be on when you check it
Release.
as well as when you are inside.
Release.
Now again the brake has been released.
Yes,
Now
yes.
we'll go in.
Yes.
Yeah, you can this is what you would always want to have the knob maximally distally,
That's
so
right.
that much of you have almost 7 to 8 centimeters of burring space. So
Yes.
keep it towards the end, but then unlike rota, you don't really have to have it in the middle portion, and then you do not have to release tension much, because you most of the time when you go with the glide assist mode, you wouldn't develop any tension inside this.
That's right.
And it easily navigates inside compared to rota. It's much more
That's
easier.
another advantage.
Much more easier.
Yeah, I have one advantage. Can I use this one?
See, we are not even pulling the okay.
This one. Okay. 1 minute. Yes. Yes. As a single operator, you want to do. So, no?
You could always do that. You could always do that.
Yeah.
Glide assist mode, you call it
Yeah.
as the glide assist mode. Okay, now we are closer to the lesion.
It seems. We can unlock. Yeah.
We've unlocked it and moved it little bit forward
Very
and
good.
backward, something like releasing the tension. Sir, you
Yes.
please go ahead.
Okay. Can we
Yeah.
start that one?
Now we have kept it at 80,000 RPM.
Yeah.
Okay.
Okay. We can start.
Yes.
Now you see.
Break.
Break. Right.
The area where we are burying right now, there appears as if there is no huge amount of calcification. Probably we would prefer to dwell more time on that particular area mid RCA, where
Oh, you saw
now
you see difference of sound?
yeah.
Can I stop? Okay. Once that sound is come, so you can stop 25 millimeters, 25 seconds. So after 10 seconds or 15 seconds, you can remind me.
Our usual habit is
Or time is over.
അച്ഛനോട് പറയണം അരമണിക്കൂറെങ്കിലും ആവും ഈ കേസ് കഴിയാൻ, അത് കഴിഞ്ഞാൽ
Can I do?
എല്ലാവരും പുറത്തോട്ട് ഇറങ്ങുള്ളൂ, ഞങ്ങൾ വിളിക്കാമെന്ന് പറഞ്ഞു. Now while doing rota, we have a habit, even though you can do it for 25 or 30 seconds, we always make sure that we stop at 15 seconds and wait meticulously for 1 minute before we do the next run with rota. But then with this, probably even 25 seconds wouldn't really produce much of slow flow, things like that. So only when we hear this sound, we stop and wait for 25 seconds at least.
Yes.
Timer on?
Timer on.
One question.
Yeah.
Once that sound, you have to stop.
Rotational, there is a role of wire bias, but in orbital, they're telling the wire bias is not so important. But
No wire bias.
Yeah.
in the large vessels, rotor is unlikely to touch the other opposite.
Very true. Very true. Except in areas where we saw that small nodules which is actually hugging on to the imaging catheter, those areas probably the rota would also help. But most of the times in these sort of huge vessels, when you have a decent lumen, when you have a reasonably good lumen, the rota wouldn't touch the vessel. But here, when you have a smaller vessel, probably this would orbit and then go touch the vessel wall. When you have a 3 mm vessel, probably when you have a 4 mm vessel, again the orbital also going and touching the vessel wall. If it's a good looking lumen, if it's a tighter lumen, probably it would certainly help. But if it's a big lumen, probably it may not reach till the vessel wall if it's a huge vessel.
In that case, IVL will be ideal.
IVL, yes.
True.
Still, as we saw in the imaging, there are areas wherein there are some nodular protrusions which actually should be able to, we should probably be benefited with orbital. That's what I hope.
True. Over 20 seconds. Okay.
Now you can see that the crown is actually moving on to the outer border of the vessel.
Yes.
The calcium is actually on the inner border of the vessel. Probably once we are done with some amount of burring, then there is no bradycardia, things like that. So at that point, what we'll do is we'll pull back the wire. So then we'll have a more of wire bias towards the inner. Now the wire is actually buckling towards the end so that it's actually hugging on to the outer wall of the RCA. So probably once we've crossed in this plane, probably to get a better wire bias, we'll pull back the wiper wire and then once again do it on the inner border.
Retro also we can do.
True. When you again in those situations when you do retrograde orbital, it mostly hugs on to the inner curvature.
Here it is.
Even though the lesion is seen till low down there till that branch, but then the calcium, we do not see too much of calcium down there. So probably there is no point in going till there. Probably we'll dwell probably more in these particular areas where we see more of calcium.
We can do
retrograde. And once again at higher speeds we'll go in with the wire pullback. With the
okay. Till edge I will do and I will come back again. Yes.
Little more we can go distally.
I'm coming back again.
No, Baradi has happened. Some retrograde will be.
It's ectopic only. That's all. Nothing actually. No Brady.
In one of the picture-in-picture, can you show the hemodynamics also if possible? Pradeep, Sheen.
Just pulling the wire.
Probably we can pull it back by around 2 to 3 centimeters. Yeah.
Yes, that's all. Then 120 I can change.
Okay. What we do is retrograde also we do it at 80,000. Then once again go in with 120,000.
Okay. We can do 80.
Yeah. Here we are much more happier because the lumen is reasonable. The flow, we are sure that the flow is going to be there even when you park the crown over there inside the lesion. When it becomes much more tighter, those situations probably you'll have to pull it back to reduce the amount of ischemia during the procedure.
But a significant change of the sound, it is less actually.
Yeah,
unlike previous.
True.
Very, very tight lesion and damping sound we can able to appreciate.
Now, once we come back little more, probably once we come up to little more proximally, then we'll switch over to 120,000 RPM. Yes. And then at 120,000 RPM, we'll again go at we'll go one more round till we are done till the distal end of the calcification. Yes. Then we come out and then go with the OCT catheter. Okay. Now from here, what we'll do is the next we'll go to 120,000. We'll also pull back the wire little bit.
Yeah.
And we'll release the brake, pull back the wire halfway through, so that we have the burr going more through the inner lumen of the inner curvature of the vessel, and then once again we'll start. Did you hear the pitch change?
With 120, you can appreciate more.
That
Compared
pitch
to
change
80,
was
more
seen.
orbit,
Ah.
large orbit.
So which means that certainly it has touched the calcium.
True.
So unless and until you hear some pitch change, you're sure that it's just flying in and coming out, swimming in and coming out. It doesn't really do anything good for the lesion. But here at least we heard at this point of time there was some pitch change.
Yes, yes. So release there. Yeah.
Yeah, we are seeing
Freaky
here.
sound will
Yeah.
you can able to appreciate. Damping, yeah. Yeah.
Now we'll do retrograde also.
Retro 120.
So this endpoint of ablation, usually we see this pitch change.
Yeah, these are the two things that say, Vishnu. Like one probably you need to have the feel of your hand, whether you're pushing against it or not. That feel is one thing, and second thing is the pitch change in the pitch. In the initial runs with 80,000 RPM, we did not really make out any change in the pitch. Change of sound. Now with 120,000 RPM, at least we are able to make out that there is some change in the pitch.
More plot sanding
More
occurred with
true.
120 because the larger size of the vessel. He can appreciate some change of the pitch.
Yeah.
It's the tightest lesion.
Yeah. Now shall we go for one more run and then switch over to the
Yes.
imaging catheter?
Yes,
Now so be ready with the run through wire. We'll do the imaging, and once I look at the OCT images, we'll go ahead with balloon dilatation with a 3.5 millimeter short balloon, 10 or 12 millimeter balloon. And once we are done with the balloon dilatation, we'll again do an OCT imaging and then go with stent implantation, probably 3.5 38 distally, and then a second one 3.5 proximally, a shorter one. I think we'll come out.
Yes.
Okay. We'll go to glide assist mode now, and then one of us will be pushing the wire, and
push the wire.
Yeah. That's 5,000 RPM. It's rotating and it's coming out. Yeah, we are in glide. That's the reason why you are hearing a. It's a small sound, 5,000 RPM only.
Yeah.
Now the wire we come out.
Yeah.
We'll switch it off.
Yes.
We'll reduce the noradrenaline. Can we stop noradrenaline? You could certainly do that because it's
laborious. That is the main thing.
Because it's much more easier to use the wiper wire than the rotor wire. You can do that because we had one situation wherein we had bradycardia, hypotension and all. We had to complete the procedure without wire changing. We had to do that. But it goes in, it's a supportive wire also.
That's all.
Give the next wire. Okay, that is what we've seen.
Yeah.
We'll go with the run through wire, and then we'll have an OCT done.
OCT done, yes.
Once we are done with the OCT, be ready with the balloon.
Hello?
Vishnu, we can hear you.
Yeah.
Binu acha.
Any doubts?
So no problem. Carry on. Yeah, I'm here.
Acha, this would take another 15 minutes or so.
Okay. No problem. I can see. Okay. Carry on. No problem.
Achha, we would want to have a photograph done with you. Yeah, it's going into the branch.
No, it's okay.
So will it be okay another 15 minutes?
Yeah, once you finish, just let me know.
Yeah, now it is.
Okay, give the OCT
Okay,
catheter. We'll take out the
Now
wiper
you
one.
concentrate on what you're doing. Okay, thank you.
Okay. OCT.
OCT catheter. Now enlarge the OCT images. We've stopped noradrenaline, right? We'll stop noradrenaline.
So does this patient have bradycardia?
No, he didn't have any brady at all. No brady,
No hemodynamic.
no
changes,
hemodynamic
nothing
change at all.
actually. He's stable.
So when the vessel become bigger, the particle going down will be smaller quantity.
Possibly. Then again the next problem is probably we wouldn't have done much with the orbital to the calcium. Didn't have much of particle going down the vessel. That also could be a reason for that. But certainly we heard a pitch change. Probably the imaging should make us understand what exactly has happened.
We can say definitely some plaque modification, just like some shallow gutters I'm expecting on the OCT
Yes.
at the tightest lesion site.
Okay, Arya, we are in with the OCT catheter.
Yeah.
Shady, come closer.
Yeah, please.
Okay.
Yeah.
Arya, we are ready. Shows the image. Yeah. Yes. Okay. Yes. Activate. Now get the balloons also. By the time I'll go
Yeah, please.
see the 3.5 into 12 or 10.
3.5
Okay.
into 12. 3 and
Get it.
3.5. 3.5 you are.
Get a 7.5 glove also ready.
3.5 ton. Okay.
Okay, so this is probably we didn't touch these particular areas. As we come more proximally, you can see calcium at 12 o'clock position, and this particular area probably some polishing has been done. That's the reason why you're seeing these sort of small intimal tears and all, intimal break and all. That is what you're seeing there. Then as we come more proximally, again this smoothened out, this polished areas, these looks as if this has been sanding has been done with the with the orbital catheter. And this again you could see that this particular area we expected that probably nothing would happen to this particular calcium with orbital. Again you can see that this particular small bit of calcium has been sanded with the calcium with the orbital. Now again you can see that at 12 o'clock position, and every area you are seeing some amount of white thrombus like thing. Probably it is intimal disruption seen. Now again certainly this has helped. You could see that at 12 o'clock position there is significant amount of calcification that has been polished. Again that actually happens at the area where the imaging catheter, you could see that the imaging catheter is very close to that particular calcified area. That is where the sanding has been happened. And as we come more proximally,
that is a gutter actually, very classical gutter. You can
yes,
that is a gutter.
This particular
created,
area,
exactly.
this particular area
created by the sanding.
Then as we come further more proximally, again these areas you can see at 11 o'clock position, that's the ablation being done. That is what we could achieve. Certainly this has helped in this particular situation. Now we'll do a balloon dilatation and followed by a repeat OCT run, then we'll go ahead with stent implantation.
Can this flower vase balloon help?
Almost till the osteum. We need 57 millimeters of stent. So we'll go with a 3.5 distally, 3.538 distally, and then we'll decide on the next whatever length we need to take. This is what 3.5 into 3.5 into
change.
the balloon 3.5 10.
14. Defect.
Now we are able to dilate it well. And again, we didn't, unlike the other case, the first case we expected that we would find it difficult to dilate with a balloon. But here we feel that we initially itself following the imaging, we felt that we wouldn't find it. We'll start little bit of noradrenaline once again. Okay, we felt that we would be able to dilate it because even if there was even though we saw there was a big chunk of calcium over there, we were sure that it was not a 360 degrees. So the balloon should definitely open up on the other side of the vessel. So we didn't expect that we'll have difficulty in opening up this particular lesion with the balloon.
But an expandability of defect. 18. Defect.
Okay, now we'll again go with the OCT catheter. Small dose of noradrenaline. Okay. Shaidi will go with the OCT. And then be ready with the stent also, because the balloon has opened up well. We do not have any intention of further modifying the plaque. We'll understand what has been done by the balloon with the help of the imaging catheter. Shaidi, a small perch. Okay, now the pressures are good. That's the OCT catheter. Okay, we are ready with the catheter. Yes. 1 second. Okay, you can do that. Activate. Now give the stent.
Yes, it is a dissection is produced.
Meanwhile, we'll see the image, sir. We'll go with the stent. 7.5 glove. So as we come more from distal to proximal, now you can see here that this is actually the area where we saw that nodular protrusion. Nothing much has happened for that nodular protrusion. Probably the stent would expand on the other side of the vessel wall. Here again you saw that there was a thick chunk of calcium. Probably we have produced dissection on the other side of the vessel wall. That's at 7 o'clock position. You are seeing the vessel disruption. And as you come furthermore proximally,
dissections.
Here we are seeing multiple dissections. And as we come furthermore proximally, okay, so that's what we've seen. We do not see lot of cracks that's been produced inside the calcification, primarily because it was more of an eccentric, unlike the other one wherein we saw that there was huge amount of concentric calcification. Here certainly the stent is going to expand, we are sure, with probably some amount of eccentricity. And if you had used an IVL, probably we would have seen some cracks in these areas also.
Yes.
And again, we didn't actually dilate these particular areas. We actually dilated only the mid portion of the critical lesion. So now we go with the stent implantation.
Yes.
3.5 38.
38, okay.
Yeah.
And then followed by optimization.
Sir, I'll go with the stent. Yeah.
boss, please. Yeah. Crossability is there. Good crossability. Yes.
That area seems to be good.
Correctly. Distal and a good bus.
We'll go up.
Good bus.
We'll go up.
Yeah.
10, 12.
That portion.
Yeah,
Yes. Now
it's
it is
opened up.
Opened up.
14 and negative.
Opened up.
And negative. No, I don't think 3. We'll have a 3.5 into probably 28 or 23. We'll just do a imaging and see.
Oh, this is 28 below bus.
Yeah.
One opened up. Opened
Yeah,
up.
now this is 38. Now approximately we'll have a
Approximately you have to
23
do-
would be enough.
Yes, yes.
20,
23.
23.
23.
23
Overlap with a minimal
Yeah,
overlap.
yeah.
28 means maximum overlap will be there.
Three 3.5 into 23, then 3.5 and 4 NC balloons. 3.5 stent.
Sierra only expandable the characters will be there, no?
Yes. Yeah, 3.
Ideal.
Yeah, 3.5, 23.
Sierra is expandable.
Jojo, don't miss. Now keep the balloons also ready
Approximately you have to optimize by 4, no?
with 4. 3.5 distally and 4 proximal. That is the stented segment.
Stent boost. In the stent it is coming, still not coming.
We are just on the floor. Stent boost, okay.
Stent boost, otherwise you won't. Yeah.
Ready?
Okay.
I think we are just overlapping.
Just.
We'll take a small cine and then this side. We are just there.
But,
if at all 1 millimeter distally. Yeah.
That's the main thing.
If at all 1 millimeter, we'll go distally. Yeah, we are just there. That's more than enough, I think.
No, only marker is overlap, not the stent.
Yeah.
Some gap is there.
Okay. Still. Proximally, we are good. Probably I'll push it a millimeter.
Slightly.
Okay, go ahead. Got it. 12, 14.
Yes, yes.
And 16. Negative.
Yes.
Now the NC balloons.
3.5 and 4.
Binocha, we'll be done in another 5 minutes.
Anything is there?
Johnny sir with you.
I will wait for another 5 minutes. Okay, no problem.
He's a director, Achan.
I understand. Okay.
18, 20. Negative.
He is sitting with so much of an interest. Yes, we'll go up. 14, 16.
It is good. Yeah.
18. Negative.
18. Negative. Again 18. Negative. 18. 20. 20. Negative. 18, 20.
Overlap segment. This is
Yes. Negative. 20. Negative. 20 and 4 mm balloon. Negative.
Yeah.
20.
This 4.5.
Huh, 4.
Yes, yes.
4 is enough.
That's what I'm saying.
We are not too aggressive with the balloons.
Yes, correct.
A reasonable lumen at the end of the day with a good stent should fetch us a better long-term outcome.
How many times you use the balloon usage? 4 times or 6
As
times?
long as it doesn't work. As long as it stops working.
That is end point.
Oh, that's it.
1 minute.
20. Negative. And then the OCT. Here we are, 14, 14, 16.
This is the overlap segment.
Yes, negative. 16, 18. Negative. That's a 4 balloon.
Yes, yes. Yes.
Okay, okay. 16, 18. Negative. Now the OCT catheter, nitro.
Yeah.
A small purge. Yes. Reduce noradrenaline. Show the OCT image, enlarge the OCT images.
Yeah.
Arya, we are almost ready here. Yes. Okay, ready? Yes. Activate.
Yes.
Distal edge, show the distal edge. Little more distal. Okay, there is no distal dissection.
No dissection.
If you look at the yellow box, the lumen looks good.
Good actually.
Most of the areas, it's more than.
Also very good expansion.
Yeah.
Distal.
Nitro. Say the nitro.
Right.
And want to see that particular mid portion where if we have any under expansion or not. Get ready with. Get me another.
That is the area.
7.5.
Exactly. But actually, there it seems good. Actually, it seems good.
Distally, these areas, it's all good.
Yeah.
5. The distal vessel is almost 5.9.
Yeah.
Here it's more than 7. All these areas are 7, 8, 9. It's all good. in these areas 8, 9 and all. And as we come more proximally here, again it's 8.
Good.
There is some amount of,
You
we'll
also
remove the
good.
rendered stent. You can see that there
will
is
come back.
some minimal
Yeah.
malposition over there, probably.
This is the area.
And here the
3.2.
areas are
That
all
is
quite good.
Good. That area also. Yeah.
Proximal also it looks good.
Proximal edge also. Yeah.
I think we should stop.
No. It's a good expansion
Good.
and opposition. Yes.
We'll give some nitro and do some final images.
Yes.
Shaidi some nitro.
Which NTG. Check NTG. You can give this. This. Oh, you give NTG.
Ah.
Yeah. You can give.
That's the final image we'll do and stop.
And flush it. This is saline. Okay.
ഇല്ല, we are done. കഴിഞ്ഞു.
Can't touch.
കഴിഞ്ഞു.
Can't touch. Yes. Just. Okay.
Yeah. Epicranial. Come epicranial.
Yeah. Ready?
So I'll finish it up with
Yeah,
the
please.
shield.
We'll give you.
Be ready with the echo machine just to make sure that there is no pericardial. Okay. Arya, we are ready. Contrast. Change the contrast. Okay. Hello, cranial.
Yes. Yes. Sufficient. Action.
That's it.
Same.
Joel, check the pericardium also.
That. Yes.
Angle കഴിഞ്ഞു കേട്ടോ.
Okay.